Hi everyone, welcome to Ask Giri, the Physio Show. Your host, Giri Srinivasan. This is season 3 and episode 12. If you haven't seen our previous episodes, you can always visit physioshow.ca. We archived all our episodes there, kind of discussing various different topics related to your musculoskeletal and neurological health. Okay, go visit us or watch us on YouTube and give us your comment and feedback. If you like these things, share with your friends and family so everybody can be educated. Our motto is to educate and empower the community. Let's get into today's topic. Diagnostic labeling and lower back pain. So that is our topic. You must be wondering, what is this diagnostic labeling? It's very common in mental health also, and also you would have experienced, people, kids called as ADHDs and things like that, a lot of different labels, different diagnoses. We're going to discuss about that, what are the benefits of that, and what are the, effects, harmful effects of that, and how we should be careful in how we label people and how we communicate to our patients. Let's get in right there. So what is diagnostic labeling? Why it is there? Because it allows the clinicians, the physicians, the physiotherapists, all the healthcare professionals and researchers to kind of group the members or the patients into one category, right? So that they can provide proper treatment or provide investigation and kind of talk to patients about expected outcomes. That's why we need to be able to label and group people into one category. Okay, these guys have osteoarthritis. These guys have rheumatoid arthritis. These guys have gout. So we know what medication to give for gout. We know for osteoarthritis how to manage. We know rheumatoid arthritis, what medications, what changes we have to do. So that is why labeling came into effect or diagnosis. So what are the benefits? We just talked about it. Is it a very efficient way to understand a large amount of information classified under one category? So that's very important. And also it easy for the clinician to explain to the patients, hey, this is your condition, this is the normal symptoms, these are not the symptoms, and this is how you have to manage it, and you might need surgery for this, you may not need surgery for this, things like that. So to educate the patients about that, right? And also the third one, we see the point here, and interventions, to plan interventions. For this condition, we're going to do this procedure. Because we have done it before, we know it works. So these are the reasons why we need diagnostic labeling for. Okay, before going further, I want to share a patient story of mine, right? This patient is a very popular financial advisor. Let's call him Mr. Smith. One day, Mr. Smith walks into my office, referred by one of my old patients with severe lower back pain. He walked very slow, bent forward, and lots of pain. Looks very depressed. And he came and sat on a chair, and we started talking about the history and everything. The first thing he said, wait a minute. He took his cell phone out and he scrolled down his pictures and showed me the pictures, right? This is my back. That was actually an MRI of his back, right? And he showed me things. Look at this. I've been told I have severe degeneration in my spine, multiple disc bulges. This is the reason for my pain. Then he is so depressed and he's taking narcotic patches and everything, so many pain medications. He's seeing it's a living hell. It's very depressed, right? And he's been told those things. Then first thing once I finished the history and everything, when I started the treatment plan, first thing I told him to delete that picture from his phone for his well-being. Because he's been looking at the picture every single day and going into the mode, okay, what's happening to his back? Oh my God, degeneration. Oh my God, disc bulge. But it's our job to educate him what is normal. Disc bulges are a normal finding in a male over 40, right? So it's not an abnormal finding unless you have very severe symptoms which might or might not correlate to the disc bulge. And degeneration is also common. If you can have a little bit of degeneration in your spine because you've been loading that spine from day one, from the time you stood up, right? So that education really helped him. The first session, my goal is to take him out of that diagnostic labeling based depression, and then tell him what is normal, what's not normal. And he felt much better after that. And actually, he came along really well. In 4 to 6 weeks, we got him really good, took off all my pain medications, and discharged him with the home program. Now he comes and sees me maybe once in twice in a year or something like that. And very healthy, active life. A simple communication and education goes a long way than any magic modalities or manual therapy or anything like that. So that's the importance of this. I just want to share this powerful patient story to you guys. Now, recent study. This is a study we're going to discuss about today. It's a brand new study. It came out in, it's published in Journal of Orthopedic Medicine as well. You can see that the study is effect of diagnostic labeling on management intentions of non-specific lower back pain. Okay, what is a non-specific lower back pain? It's nothing but it's lower back pain not attributable to any specific recognized pathology. Like for example, infection, or you have your osteoporosis, or you have a tumor, or you have a nerve impingement, radiculopathy. Without any pathology, you have back pain. That's called non-specific back pain. 95% of the back pain patients we see in the clinic are non-specific back pains, right? So how this diagnostic labeling affects the management intentions and the outcomes for these patients. A very interesting study I want to share with you guys. So this study is an online randomized experiment. It had about 1,375 participants. What they did is, these participants, everybody, they received one of a label of the following. So you either have a disc bulge or degeneration or arthritis, lumbar sprain, non-specific lower back pain, or episode of lower back pain. These are the 6 labelings given to this 1,375 participants, right? What is the outcome? The outcome is their belief about they would need an X-ray or MRI, right? The belief about what the need of imaging. That's the outcome we expected. So what's the results of the study, right? So the need for imaging, the need for second opinion, the need for surgery, the need for increased pain medications were rated much lower for the people who got this following labels: episode of back pain, lumbar sprain, and non-specific lower back pain. But the people who have got disc bulge, degeneration, and arthritis have quite a bit of expectations about that needed surgery or imaging or a second opinion. So it's a very interesting study. Oops. So I want you to understand the effects of diagnostic labeling on that, because diagnostic labeling increases the cost of the medical treatment and the paramedical treatment, and also sometimes over medications, over hospitalizations might happen because of that, and also heterogenic harm can happen also. So those are the ill effects of diagnostic labeling, and it has its own role in the mental health too. And there is a lot of research papers out there. What do we call people? ADHDs or depressed or whatever it is, schizophrenic, and how the medical community and other community view that labeling and how they treat the labeling is that's a different topic. We'll talk on another day. Now we also have to talk about self-labeling. Self-labeling as patient, what you talk to yourself, right? That is very interesting thing. That also has to go because your brain is listening to that all the time. That means the process of acquiring a belief about oneself. What do you call yourself? These are some of the common things I come across in my practice. I have a bad back all along. It runs in the family. You can't change it, right? So they judge a part of the body as being like, as like separate parts, like, lower back is separate, neck is separate, hip is separate, knee is separate, ankle is separate. They kind of think everything is separate parts. And judging that way is not a great thing, because you are one whole person. The brain sees you as one whole person, not into separate body parts, right? And same thing goes when you work out too. That we'll talk later. So when you divide your whole body into different body parts, you will cause excessive worry about that. And also, when you identify your body part as a bad thing, for example, I have a really bad shoulder, okay? And when you assess, also people say, this is my bad shoulder, this is my good shoulder. So immediately we have to change that language. I usually tell them, no, that's not your bad shoulder. That's your right shoulder, which needs some help. That's your left shoulder, which doesn't need help. So as a clinician, change that language, change that self-labeling, how the patient perceive themselves. That's very powerful. That's very, very powerful in that. Because when you keep telling this is bad, this is bad, this is bad, your brain is listening, right? That can itself make your pain worse. So that's very, very important there. So other bad self-talks, what we come across in the clinic. Oh, I have pain because I'm getting old. Old age is crazy. The research says otherwise. It's actually quite opposite. As you get older, older adults does not have a lot of chronic pain, right? And the research says that. So as you get older, you're getting pain because may not be moving well. You may not be moving in different directions. You restrain yourself in a small boundary. Maybe you're just doing only walking. You're not doing any resistance exercises. You're not any power training because you think you're old. So that is not the right thing. And the other one is, oh, the MRI said I have disc bulge. The MRI said I have this. The MRI said I have this. MRIs has its own value. MRIs cannot define pain, right? MRIs are there. It's basically, snapshot in time about one joint. It is there to find out any structural changes or pathology which requires immediate interventions. MRIs doesn't tell everything to you, right? MRIs doesn't talk about all the factors and effects of so many things. Does MRI tell you about your circulatory system, which brings nutrients and oxygen to your tissue or the body or the joint or a bone? No. Does MRI tell you about your endocrine system, which takes care of all the hormones and neurotransmitters which can tune up and tune down the pain? No. Does MRI talk about your psychosocial factors? How your mood is, what is your previous experience with the pain, how is your social status, what's happening at work, what's happening in the family, what kind of sports you're playing, how you're preparing for your sports? No, MRI doesn't tell you that. So these are things we are talking about. Does MRI tell anybody how you move? How you do certain activity? No. So that is why you need a physiotherapist, a movement specialist to look at you, not just the MRI. MRI has disc bulge, so what? Right? So 80% of people have disc bulge over 40 to 50 years. Not everybody has pain. Not everybody has non-specific lower back pain. So consult your physiotherapist and don't just go and dwell on the MRI alone. And then another common thing you hear is, I have bone on my knee, right? Yes, cartilage, all these years, you walked and you did few things, you played sports and the cartilage kind of on out. And yes, the bone might be rubbing on the bone, so be it. It's not a factor you have to cry about. You can still move on, you can still do so many exercises, you can still be active. You just might have to modify certain things and do some stuff according to your physiotherapist, that's all. You don't have to stop your activity, stop doing everything. Oh, my back goes out every month, I have to put it back. Your back doesn't go out anywhere. Going out is a very big term, means dislocation. If you're dislocating your spine, most likely you'll be hospitalized. And right, and it's a very serious issue. So sometimes the joints can be stiff, which has to be mobilized or which has to be done some mobility drills. It'll be better. And then think about, I'll never get better. I've consulted so many people. Nobody can fix me. Nobody has to fix you. We are not fixers. We are your coach. We'll tell you what to do. We'll guide you to the right path and you're going to do it. The fixing mentality is gone. That's what we did before, right? I will fix you. I'm not going to fix you. I'm going to help you to get better. I'm going to educate you, empower you, show you the ways to get better. So that's what I want you guys to understand. So we are responsible as licensed healthcare professionals, right? We are responsible for feeling of the safety and threat the patients experience. So we have to be very careful how we talk to our patients, what kind of message we are giving them. I have heard from some of my patients, medical professionals have told them that, oh, it's been 2 years after your stroke or spinal cord injury, you cannot expect any recovery. I beg to differ. I'm doing neurological physical therapy for 24 years. I've seen improvements even after 10 years after stroke and spinal cord injury. So never rule them out. Never take that hope away from them, saying that you will not improve after 2 years. That's just a neurological example I'm saying. So you have to be very careful what we are talking to the patient. Because we have taken oaths like do no harm, right? That's very important. It also means what we tell our patients and how we communicate to them and what we tell ourselves about things as well. I hope you understood about diagnostic labeling and self-labeling, the good and the bad about them. So if you're a physiotherapist, be careful how you talk to your patients. If you're a medical professionals, kind of review how you're saying or what kind of communication you're having. See how we can change the language a little bit for the benefit of our patients without creating the fear and anxiety and the depressing thoughts in the patient's mind, because brain is very important, right? And how we think is how we act. Okay, until I see you next time. Bye guys.